Uh, so I work with Professor Cleland over at the Robertson Centre, the Institute of Health and Wellbeing, and my research is all about iron deficiency and anaemia in patients with heart failure and in those at risk of heart failure. So I'll try my best to squeeze it into 3 minutes. I'll discuss a little bit about the background, what we know already, some of the studies that we've done already, and what we're working on at the moment. So what do we know already? Well, we know that iron deficiency and anaemia are both common in heart failure. Iron deficiency is present in around half of patients, and anaemia in just under a third. Iron deficiency is the most common cause of anemia in heart failure, but it's also a substantial comorbidity in patients before anemia develops. Now, why are they important? Well, they have obvious hematopoietic implications, so a reduction in hemoglobin, reduction in oxygen carrying capacity of hemoglobin, but they also have important extra hematopoietic things to think about. So particularly with iron deficiency, it's an important cofactor in enzymatic reactions within the cell and mitochondria, and ultimately it will lead to mitochondrial dysfunction and disordered energy production. And it's not unsurprising that this contributes and translates to worsening symptoms and quality of life in patients with heart failure, but also translates to worsening mortality. With regards to treatments, I'm not going to focus on treatments of anemia, but we know with regards to iron deficiency, that intravenous iron addresses some of these issues, improves symptoms and quality of life. But we currently have not a lot of data with regards to its impact on mortality. A key focus of the thesis and my research is regarding the definition of iron deficiency, and it's controversial and arbitrary at the moment and is not universally accepted, and it's something we're looking into in a lot of detail. So I'll present data for a couple of things that we've done. First of all, what we wanted to think about was looking at longitudinal changes in iron and anemia status, because the vast majority of research has really been done and focused on prevalent disease. So using data from the Hull Life Lab, which is very quite representative of standard heart failure population, and just over 900 patients over a year, we had blood tests at 2 time points, and we essentially showed that the situation is really quite dynamic. So over 1 year, between 70 and 84% of patients will either have or develop iron deficiency or anemia. And we had a look at how this translated into outcomes, looking at different definitions. And in general, patients with persistent iron deficiency, irrespective of how it was defined, had the worst outcomes. And specifically looking at those who recovered from iron deficiency, we showed that mortality was reduced in patients who recover from iron deficiency, but only when defined by a low serum iron of less than or equal to 13 micromoles per litre. So this performed better than the other definitions. And interestingly, what we found, contrary to some other reports, was that anemia was essentially bad for you, irrespective of whether it resolved or not. Some more data. So one of the other things we wanted to look at was, I mentioned about mortality data lacking in intravenous iron trials. Now, that's because trials up until recently have looked at surrogate endpoints mostly, moderate sized trials, but this is until the Affirm AHF trial was reported late last year. It was the first outcome trial using intravenous iron in patients with heart failure. So we wanted to update the pooled evidence for this to see how successful intravenous iron was, particularly looking at heart failure hospitalisations and cardiovascular mortality. And what we showed was in 7 trials of over 2,000 patients, it appears that intravenous iron does appear to reduce the risk of hospitalisations for heart failure and cardiovascular mortality in the subsequent 6 to 12 months. But this was really predominantly driven by a reduction in heart failure hospitalisations. So looking forward to the outcome data from the current trials in patients with chronic heart failure. Briefly, just other things we're looking at. We're looking using the safe haven data that Professor Cleland mentioned previously, looking at our current behaviours of clinicians and cardiologists. Are we considering iron deficiency and anemia? Are we testing for it? And how does that translate into risk? Are there differences in iron deficiency prevalence and associations depending on how heart failure phenotypes? And this has really been poorly reported in the literature, so something we're looking into. And particularly we're looking with the definition of iron deficiency I mentioned earlier. We're hopefully soon going to start recruit our first patients to a large observational study in patients scheduled for cardiac surgery by comparing gold standard bone marrow iron stores with serum markers of iron deficiency to try and find an appropriate biomarker and the best threshold for that given biomarker to define true iron deficiency. Okay, thank you very much.